So, welcome and good morning also from my side. I'm Jens Fiehler. For the ones who don't know me, I'm from Hamburg in the north of Germany, and I'm from the university hospital there, University Medical Center, and we have quite a long experience in interventional neuroradiology. And it started in the 50s with neuroradiology, and I was taught by Hermann Zeumer, who was the first person to do interventional stroke treatment in the late 70s. And now I'm going to present you some experiences with the DERIVO flow diverter, and the background is that we are a teaching hospital, university hospital, and not all the treatments are done by only hugely experienced guys. That's why our results may be not particularly perfect, but it's just a reflection of the real world experience. These are my disclosures, public funding and consultancy for many companies. The DERIVO flow diverter, for those of you who are not familiar with this device, is a so-called second-generation flow diverter. It's made out of nitinol with so-called Pluke side surface. Should be helpful first for visibility and second also for minimizing aggregation. And it's available for vessel diameters between 2.5 and 6 millimeters, so it's also very nice for larger diameter carotids, for instance. And there is even a version that is 80 millimeters long, so this is really impressive. But of course, this has other downsides. It's compatible with 27 microcatheters, and the design is a single layer, unlike the FRED, for instance. Consists of 24 nitinol wires only, but has a porosity of 65%, so it's quite dense in the middle. And the visibility used to be quite poor in the older version, but it's now much better with the new version. And this is it has a bit of flared ends with these iridium markers, which improve the visibility, but in fact they are not required from my taste, because the overall visibility is quite good. So these are the microcatheter that you can use to deploy the DERIVO. So they are essentially the ones who work best are the headway and the single, the VIA from Sequent, now Microvention. So we typically use the headway 27 for our procedures. There are some animal data have been published last year with the next generation, and it showed a hugely improved complete occlusion rate, but I think you hardly can derive much information from this animal work apart from it's feasible, covered branch arteries remain patent, and so it's comparable to the first version, but seems to be a bit more effective and much better visible. And there are, from the first generation, there is one paper that I found that reports 34 aneurysms in 24 patients. Headache was the most frequent symptom, which sounds a bit strange to me. Most in anterior circulation. Deployment was always successful, which is always a bit of a red flag for me, because nobody is successful in 100% of the cases. 70 to 80% full occlusion rate after 3 and 9 months. Morbidity 8%, mortality 4%. So it's a bit, let's say, first try. And now my own experience in our hospital, in the University Medical Center, this is the data that we collected with the DERIVO within 2 years in 2016, 2017. So we started with flow diverter treatment in 2007 with the silk and also with the pipeline. Shortly thereafter, we made very poor experiences, so maybe we were just stupid. We stopped doing flow diverter treatment until 2013, and then we started new. And we were really convinced by the DERIVO when it was presented in the second generation. So 2/3 were treated in the anterior circulation and 1/3 in the posterior circulation. Half of the aneurysms were incidental, so truly incidental, because I don't think that many of them really cause headaches. There are some, of course, but not many of them. And 16% were retreatments after previous treatment attempts with coil, clip, or floor diverters. And 6 had brain nerve palsies, 5 of them ophthalmoplegic, 6 SAH cases, 2 were symptomatic by TIA, by embolic symptoms, and 1 with an ICH. What were the experiences? Technical success. We were able to deploy it in all but 1 case after some pain sometimes. A simple procedure, whatever this is, of course it's very arbitrary, was done in about 70% of cases. In other cases, we had difficulties in accessing the previous flow diverter that was deployed. If we definitely used the balloon for proximal end, and if the flow diverter was not deployed at all. Clinical outcome at discharge in asymptomatic patients was 10% morbidity. We had 2 times 1 time a TIA, and 2 times the ophthalmoplegia went worse. So this is something I think we are all familiar with this problem, because they may be inflammatory processes or increase or thrombus formation. So this is something that is a rather frequent finding. 0% mortality, and what really stunned me when I prepared this presentation is that we had 6 cases with an SAH, and 4 of them died. So we have a mortality of 67% in SAH cases, which is a lot, but on the same time, it's only 6 patients, and I will share with you 1 case which has certainly nothing to do with the device as such. It's really hard to tell, is it device-related, is it procedure-related? We didn't observe a clear device-related morbidity in the remaining 2 of the patients. So this is certainly not reason for concern, but it depends on the case selection. Follow-up, we had 26 of the 44 patients have at least 6 months elapsed since the last procedure, and from them, so if we could have a follow-up, we have 88% of follow-up in these patients. Most of the time, combination of MRI and DSA after 6 months. So 12 patients after 6 months had incomplete aneurysm occlusion, 7 had complete. So we were really strict with not a small residual flow is still incomplete. So this is counted as incomplete here. And 11 patients had more than 12 months follow-up, so 7 complete and 4 incomplete. So you can't make a big statistic out of this, apart from the fact that it doesn't seem to be very special what we observe here. So now, as mentioned, I'd like to share with you 2 cases just to illustrate how the device looks like and how it performs. This is an incidental supraophthalmic aneurysm, or you can call it 2. It looks a bit ugly, atypical. The vessel diameter is 4.8 to 5 millimeters, and then you could ask yourself, should I prefer a 4.5 or a 5? And this is what we did. We started with a Sophia 5 French intermediate catheter. It didn't have enough stability to really deploy the DERIVO here. Then we changed to the Navian, which was a bit better choice in this case. Headway 27 used the DERIVO 4.5, and we had to do a lot of push and pull maneuvers to kind of shape it into the right form. And the goal was that the proximal end should be distal to the anterior choroidal artery. And this is how it looks like. You see here in the unsubtracted image, you can really see how it deploys. on its entire length. So the markers are nice, but they are not really required. So what you see here are obviously not the perfect lighting conditions and not the best image quality. So when you see it here, it's fine, but what you also see that there is no expansion, no full expansion on this curved segment, and this is mainly due to the fact that we had to manipulate so much to get it into shape. So what did we do? So this was just discussed previously. We used the balloon. We usually use a scepter balloon, but we also have used the Neurospeed balloon as well. And this is the scepter C410. And so we were able to adapt it to the wall. But the question is this a really stable situation? So what you see it here, I hope. So I think it looks good, but this was the discussion point. Is this really stable if you inflate the balloon and hope you change the geometry of the struts in a way that they remain in this shape? So what did we do? We decided it's not stable, and we placed another one over the first one, and this was much better than. So I think this is it's a nice shape and a nice stable situation, and this is how it looked directly after deployment. So no really impressive flow diversion effect. This is how it looked after the procedure. You see some clot here, thrombus inside of the aneurysm. And after 7-month follow-up, it shrunk. So most of it is gone away. And if you say, okay, I only trust the angiography itself, so what you see here is aneurysm as such is gone. This is a nicely shaped siphon here. So I think it was a good choice. I'm not so sure that it was really required to place second DERIVO here, but I think it's okay. Second case, one of these subarachnoid hemorrhage cases. What you see here is the original CT scan. You see the distribution of blood into the insular cistern here, and you already suspect that something's going on here. And this is how the aneurysm looks like. You have an atypical aneurysm, fusiform. In fact, it affects the entire intracranial vasculature, this disease. She also has an aortic stent, this lady. And it seems to be an entire affection of the entire vascular system, maybe dissective. So what you also see here is the kind of stenotic segment. That's what we just discussed during after the last presentation. So what do you do here? Okay, you have a hemorrhage, but are you sure that this aneurysm is responsible? Most probably yes, but can you avoid a rehemorrhage? I hope so. So what we achieved is we placed the DERIVO here from here to there, and what we were able to do with all these pushing maneuvers, with this manipulation, we also modified this stenosis. This was discussed. So with the DERIVO, at least, it's possible that you have so much radial force that you modify this stenosis, and we didn't feel that we had to use a scepter balloon to PTA this stenosis. So what we saw here is we felt that we had torqued the device, which didn't exactly help with deploying. But in the end, we managed to resheath it several times and to milk it out in a way that it was placed in a good shape here. So again, here what you see here is that the stenosis here So I tend to say it looks better than before. At least we didn't feel the urgent need. It's better, isn't it?
Maybe it's a spasm, no? Spasm.
Could be, but at least it's not a spasm from the SAH, because the SAH was very acute. So maybe, but I don't know. What we use is Agrastat, and then we injected aspirin IV and started with clopidogrel. And that's a very important question also for what I'm showing very soon. No. Maybe I should be. Maybe you are right. So we usually don't use coils together with a flow diverter because in acute phase. Yeah, this is one of the examples where we could have placed coils because there's something aneurysmic. But there are also other cases where it's very hard to do because it's just a dissection, it's just very fusiform. I think it's a very, very good comment. What we saw, patient went fine, was extubated, improved, but after 11 days of ICU care, she deteriorated, had anisocor pupils, and in the CT we saw a new hemorrhage. And the distribution of the hemorrhage is very on the basis here around the brainstem. And I tend to convince myself that it has bled from another source, but Nader is not convinced. No. Okay, there's no blood here, but blood there. I didn't bring it to me. It looked ugly as well, but no really aneurysm that looked reasonably treatable. So theoretically, we could have treated this lady with flow diverters all around. But there was no real aneurysm in the posterior circulation. So we decided that she had bled from another source, but maybe we are wrong. Nader, you would say you should have placed coils?
Yeah, well, the artery is plastic. It's very difficult to navigate.
Yeah.
To put a catheter and to put the stent and then some coils. Maybe you should postpone your intervention like 1 week after, put only one antiaggregate just to avoid this risk. But it's always risk. It's a dilemma in this kind of situation where you cannot treat.
Did you have a reduction on the angiography of the flow inside the aneurysm after the DERIVO?
Not much.
Really?
Not much.
So you give a lot of antiaggregation. The flow takes months, years sometimes to decrease. So in a ruptured situation, safety maybe to add on.
Yeah. But how good is flow reduction an indicator for decreasing the rupture risk or re-rupture risk? I think it's intuitive. It's intuitive, but not necessarily true.
For the rupture risk of aneurysm, unruptured, treated by flow diverters, there is tendency of placing coils if you see the same angiographic aspect and with a dual antiaggregation.
Mm.
Or an occlusion test and
Yeah. Yeah, but in this patient, because it's a total mess.
Patient have very good collateral flow. It's really simple. And for me, very simple possibilities is occluded of carotid artery with conduit. And very simple and without problem. I think it's very good, not only reconstructive operation, it's good in this situation. And this without residue, this very good, but flow is work, very good. And the flow diverter is very strong device.
in acute phase you will have vasospasm. So it's we don't like to sacrifice an artery in acute phase. Yes. It's a very
Yeah, we were not happy with the entire situation, obviously. So you have to.
Another analysis are coming.
I'm just aware that she has yeah.
No, it's not easy.
Yeah.
We can discuss, of course, if you should put coils or not in this case, and sometimes it's bleed, sometimes it doesn't. But this hemorrhage, it's not from that aneurysm. You have the hemorrhage in four ventricle, and you don't have in the lateral ventricles. So it has to be something from the posterior fossa.
That's what we thought.
I think it should be from posterior fossa. I don't know how the carotid aneurysm can give force ventricle hemorrhage.
Yeah,
So
that's what we
in this
thought
case,
too.
I don't think so. There is
Yeah.
some relation with the other aneurysm.
Yeah.
What do you think?
Probably it was just destiny, more or less, that this happened
Or
because of
something,
the.
some dissected aneurysm, small one from the vertebrobasilar system,
Yeah.
or something else, but it has to be from posterior fossa.
Is the patient hypertensive?
Yes, but she was under treatment. But you mean during the post phase on ICU? So the standard is that it shouldn't be but they I don't know. In this particular case, I just don't know. So obviously there are standards to have a high normal rate of blood pressure in these patients, but that's about it.
Necropsia?
No, it's really difficult to get approval in Germany for this kind of thing. It's very sad.
I think it's important.
Yeah, absolutely. We could learn so much. In this case, I wouldn't need to stand here in front of you and say I'm thinking this and that. I just would know what I could tell you.
Question.
Just- yeah.
One quick. Well, I agree with Luisa about this being a different location, especially because you don't have Sylvia Fisher blood, you don't have any lateral ventricle blood that could track down to the fourth ventricle. So most likely, if there was
Yeah.
something odd in the vertebrobasilar system, that's more likely what
Was
rebled.
in a single oddity, the entire vasculature.
And the question is, for everyone, what's your protocol for treating with flow diversion in the acute phase? Or if you have one. I've been using pipeline for 6 years only. I have 10 cases that were planned to do. Since the beginning, my protocol was wait 7 days and then treat. Always for something that cannot be done with something else. And out of those 10 cases that were planned to be done with flow diversion, at the 7th day when we were in, aneurysm happened to be larger. We were able to put some kind of coil in and treat differently in about 3 of those cases. So we ended up treating 6 or 7 with flow diversion that were true bleb aneurysms. And I happen to have one next Tuesday when I come back that I'm going to do. And that was my question. If you treat on the day of the rupture, the following day, do you wait 7 days? I wait 7 days. In the morning of the procedure, we load the patient with Plavix around 4 hours before we plan to do the procedure. And then we go ahead and put the flow diverter. But they all have been bleb aneurysms, never an aneurysm that you can put coils or balloon assisted
Sure,
or stent assisted.
absolutely.
I don't agree with you. I think I don't see the reason why waiting. I think this is more dangerous. And if they're gonna re-rupture, if they're gonna re-rupture, they're gonna re-rupture during those first 7 days. We both agree that those aneurysms are complex aneurysms. If we decide to treat a ruptured aneurysm with a pipeline, it means there's no other option better than that. So if you're gonna go ahead and treat it, I mean, you're gonna take the risk. It's gonna be an increased risk. But what we're doing here, waiting 7 days, so we're taking the risk of a re-rupture, and then we're taking a risk of using a pipeline in a ruptured aneurysm. So this is why in those cases, what I do is, first, we're very aggressive placing ventricles on those patients, so the ventricle is already placed in. You don't have to worry about that. And then I load the patient at midnight. So what I do is I do the angiogram. I decide that this I'm going to treat with pipeline. I keep the sheath in. I load the patient at midnight, and then I take him the first thing in the morning. So the patient will be at risk for 6 hours from midnight until 6 a.m. when we take him to do the procedure. So this is our protocol.
Well, that was the reasoning. If the patient is going to re-rupture, he's going to re-rupture with the flow diverter. And then you're going to have him on Plavix and aspirin, and then it's going to, I mean, it may be worse than if he re-ruptures not on any anticoagulant. And then if he re-ruptures, then he re-ruptured, and you can treat after.
What we use in acute phases when we want to put a stent. When we want to put a stent and I don't like to preload the patient and wait a few days, we can use Cangrelor, which is like RioPro, but the life, you can, when you stop it, after 10 minutes, it's finished, the action of the Cangrelor. So we use now more and more Cangrelor, you inject it with aspirin IV, just like 10 minutes before you put your stent, and when you stop it, it stops like 10 minutes after. You don't have like a RioPro, you have to wait till next day or whatever.
But what are you bridging with? So it's gone, so the effect is gone, and at that time, what are you relying on?
We prefer Plavix to Brilic because you have more bleeding with Brilic, but we prefer also to test the patient for Plavix. So we cannot test the patient for Plavix, so to avoid the resistance, we put Brilic after.
We're mixing.
There's a window.
No, you inject aspirin.
Yeah.
You don't have aspirin IV.
Okay.
So
We're mixing everything here. The first question is when to treat a patient. And the second question is which antiaggregants. And if we mix everything, it's going to be a big mess where we can't find out. So to the first point, when and how to treat him at the acute phase, either you wait, as you suggest, or you do it immediately, and then you have to compare how many bleed when you wait and how many bleed acutely, and maybe acutely it should be also compared with coils and without coils. And as long as we don't have this data, that of course nobody has, it will be difficult to give statements. For antiaggregants, it's even much more combination. Yeah. No, I don't say of saccular aneurysm, but the aneurysm that Jens showed is a non-coilable aneurysm. We all agree, but gelling a catheter and putting some coils immediately after placement of a flow diverter is something which is Deme also shows this a couple of times, and we do it also to deploy the stent partially. Then you add some coils, even if it's a very small blister, and then you finish to deploy your stent. I mean, there are many different ways to play. So adding somehow some coils in a blister or more fusiform may be a point to consider too.
Okay, so just to finish my subject here, it's about experience with the DERIVO flow diverter, and this is Christian Taschner from Freiburg, and he's the PI of the DERIVO flow diverter registry, and the idea is to have a prospective registry. Clinical outcome at 18 months is the primary endpoint, not occlusion rate, but clinical outcome. And the important thing here is that it has an intention to treat approach, so you need to register before you do the treatment, and then we can really understand in how many cases it was decided otherwise or went wrong, and it really avoids cherry picking. And this is what we suffer from with our single center case series, that we have huge perfect outcome, and this is avoided with this. So this has been presented by Christian at the WFITN. 94% patients of the 100 are enrolled, so we can be pretty sure that it will be stopped soon. And this is the complication rate of half of the patients that are enrolled. So thrombotic occlusion, excuse me, in 2. thrombus formation in another tooth, some distal emboli. So this is all core lab evaluated, so very critical situation. So if I may, I would like to conclude the experiences with the DERIVO. So from our standpoint, it has very good visibility, also compared with the other flow diverters. It allows accurate placement, or at least allows you to understand what you are doing. It's quite helpful. It's mechanically really robust. We didn't destroy it so far, even if you are in a teaching situation with less experienced people, you can play with it a lot. So it's not fully resheathable, but 90%, 80%. Has a very predictable opening behavior. What you saw is if it's under much tension in a curved anatomy, it doesn't open up, but you find ways to get it going. Preliminary data show that it's a comparable safety efficacy profile to other flow diverters. You cannot say it's inferior or superior or anything different. And I'm really looking forward to the DERIVO study, which will be published very soon, I hope. Thank you.